Our speakers for the session include Dr. Allison Blodgett of University of Massachusetts Medical and Dr. Julie Simpson of University of New Hampshire. For the past 4 years, Dr. Allison Blodgett has served as the Director of IRB Operations at the University of Massachusetts Medical School. She is a certified IRB professional and holds a faculty appointment in the Graduate School of Nursing. Prior to joining UMMS, Dr. Blodgett served as a member of the University of Maryland College Park IRB. Dr. Blodgett, please take it away.
Great, thank you. I really appreciate the introduction, and I'm so pleased to be presenting here today with Julie Simpson. And I'm going to talk today about sort of home is where the IRB is right now, the effect of COVID-19 on our IRB operations. And I usually like to start off just taking a minute to make sure that folks know what the IRB is. So it stands for Institutional Review Board. We're a compliance committee at the institution. Any institution that gets federal funding and conducts human subjects research is required to have one. It's a committee of people. They review, approve, and monitor research on human subjects. Within the UMass system, each of our campuses actually has its own IRB. So as I walk around the state here, starting at the top, we have a campus in UMass Lowell, a campus at UMass Boston, a campus down in Dartmouth. I'm at the Worcester location, so we're smack dab at the blue dot in the middle of the state. Amherst is the flagship campus out in the western part of the state. And the medical school covers the campus in Worcester. So we have a School of Medicine, a Graduate School of Nursing, a Graduate School of Biomedical Sciences, and we are the IRB of record for our clinical partner, UMass Memorial Healthcare, as well, which is its own legal entity, involves several hospitals and several practices. The med school does actually have a campus out at Bay State as well, but that's its own hospital, own IRB system, and we actually negotiate with them as to who will serve as IRB of record whenever any of our students are conducting research out there. So we manage about 1,000 active protocols, and roughly 12% of them require review by our full committee or our convened IRB. So that's the green wedge in the pie here. And that might sound like a very small number, but 12% is actually volume enough for us to have two-hour meetings each month over the course of the year. So we don't take summers off. We actually run year-round. We happen to meet on the first and third Tuesdays of the month. Our IRBs are generally separate people, but they are not specialized in any way. At some institutions, you might have one do new studies and others continuing reviews, or you might have biomedical and social behavioral. We do generally biomedical research, as you can imagine, given the makeup of the campus. And we're really very fortunate in that each of our committees does have representation from librarians on it, which make a special effort to do that over the years, and that works really well. Our librarians are very active with our medical students and our faculty as well, so it's nice to have them on the committees when it comes time to review submissions at meeting. That 12% volume of submissions that require review by the full committee, these are typically our investigational drugs and devices. We do a lot of that type of research, everything from first-in-human phase 1 trials right through to post-marketing, things that have made it to FDA approval, although that by itself typically does not require committee review. We have a very robust oncology or cancer program. We do a lot of neurointerventional radiology. We do a lot of muscular dystrophy, both in adults and children. So we have a lot of research that is greater than minimal risk, and typically everything that goes to the committee is greater than minimal risk, although there may be submissions there that just didn't fit the regulatory categories that would allow us to review it outside of a committee meeting. So for example, if we have an investigator who wants to collect a little bit of blood, but they want to draw it from patients 3 times a week, that will bump it up to a committee meeting, even though the committee might come back and say that that procedure is actually a minimal risk activity. So that means that the vast majority of our protocols actually undergo a non-committee review process. By definition, they have to be minimal risk activities. They fall into a couple categories. Exemptions are types of research that the federal government has said technically don't require IRB oversight. Like most institutions, we do still keep oversight of those activities. We just don't require an ongoing review process for them. There's a sort of exempt on steroids under the revised common rule, which is a limited review, has to be done by someone from the IRB. We focus on generally the privacy and the confidentiality aspects of the study, and everything else falls into what we call an expedited category, which is not necessarily fast. We prefer the term non-committee review. But all of these do have to be minimal risk. As an academic medical center, we generally do a lot of secondary analyses of existing data, so medical record data, some with informed consent and some that meets a waiver of informed consent. So as individuals, as patients, you may not be aware that there's a lot of really important research that may get done without your knowledge, but it's done with IRB oversight. So we make sure that the information is kept secure, it's kept confidential, and the information about you is not revealed in publications. We also do a fair number of research involving interactions with our patient population, also the students on campus, our employees, which can include residents, medical residents, and also the community others. But a nice example of some of the type of research that we do involves actually mobile medical applications. We have a number of really robust programs for both working with substance abuse populations and also reducing risk of suicidality among patients. So I was asked to speak about sort of life before and after COVID-19. And, you know, when I think back very fondly to February, I feel very much like Julie Andrews sort of rolling through the alpine meadows. And now, once COVID-19 hit, it's more like riding a bucking bronco that has let up only a little bit, but it's still very much a wild ride. There's a lot of managing both of investigators and protocols in order to protect the rights and welfare of subjects, but also make sure that our research enterprise moves forward. Now, that picture of Julie Andrews is a little bit of a farce. Because also when I think back to February, managing our other protocols, even though we have a really awesome staff, we have 6 full-time protocol specialists, we have a really great set of IRB chairs, really wonderful set of designated reviewers, but we spend a lot of time sort of working our way through very large workloads, trying to do so in a timely fashion. So I spend a lot of time with furrowed brows. So it was really, to give you a sense of timeline, back in early March, where we were starting to get a sense that we were likely going to have to go to a work from home situation. And we did move to remote operations formally on the 16th of March and really only had a few days notice to make that happen. So we had an inkling it was coming, but the institution didn't actually pull the trigger until fairly late in that second week of March. Now, fortunately, we had a meeting already on the books, of course, from March 17th, and it was lucky for us. We were in two things that helped us to be in a lucky position. One is we already allow our committee members to teleconference in, and we had moved to a Zoom format to help make that more engaging for them. So we already had that in place for our March 17th call. The other piece that helps us out is that we're already electronic based. So we have an electronic submission system and all of our materials are web-based. So PIs are able to send in their submission, the office reviews it, it goes off to committee, and all of that is an electronic process. So coming back to March, even with that standing Zoom call, our committees generally meet in person. So this was not something really well practiced among our members. So we did need to provide some support to them to be able to use Zoom, both simple things like, hey, please remember to accept that meeting invitation so that it's in your calendar. It'd be really great if you used your video camera so that we could see you. And we had a staffer put together a cheat sheet for them, so how to use Zoom to their best advantage. As reports of Zoom bombing became apparent in the news, we double-checked our security practices. We have a really great information technology group that had us in a good position to make sure that didn't happen. We did set up sort of a waiting area so that someone sort of vets who's joining the meeting. You don't just immediately join. And we did need to very quickly set up a Zoom meeting for what we refer to as our pre-meeting. So about 1 o'clock on the day of a meeting, the meeting's at 4, at 1 o'clock we meet with the IRB chairs. We walk through the agenda to see if there's anything that we need to reach out to investigators for to help move their submission through the process, get it out of possible deferral, something where it doesn't, we'll have to come back to another meeting to say a specific change that could be a modification required to secure approval. A few days after we started working from home, the institution put into effect restrictions on any in-person visits involved in human subjects, and it limited them to only those that were essential to a subject's well-being. That is actually still in effect right now. Any new enrollments into those studies do require IRB chair permission, and we take those requests very seriously and try to turn them around quickly. So you may be wondering, did we really have 1,000 active protocols come to a halt? And the answer is no, but stopping non-essential in-person visits and new enrollments for about 335 clinical trials and additional studies with in-person interactions did pose some challenges. And to help our investigators meet those challenges while making sure that we were protecting the rights and welfare of subjects, which is really our primary charge, we do have regular coordination with several other offices, including our Office of Clinical Research, our Office of Sponsored Programs, our Investigational Drug Services, which handles all those study drugs, our Information Security Group, and we made efforts to have frequent communication with our researchers, including building some joint guidance documents that when things first moved to home, we were sending those out really every day, if not every couple days. Now we do them probably about every couple weeks. And those are posted to a central website that references some other sites within the institution, so people have sort of one-stop shopping for what they need to know. We did invoke some regulations that would allow our investigators to make changes without getting prior IRB review and approval, since we would not be able to process those in a timely fashion. That exception is granted under the regulations when the changes are necessary to eliminate apparent immediate hazards. So we knew this would include things like remote visits or telehealth visits for our patients or subjects, using outside labs for blood draws, alternative ways of getting study drug to subjects. And we took the opportunity to encourage our community to use the formats that were already supported by our information security team, things like REDCap and Qualtrics, which were secure methods for getting written surveys or things signed, or also Zoom calls. And even though we allow them to make those changes, they do actually have to come back to us and report to us what's going on. Typically, those sorts of changes to eliminate an immediate apparent hazard require what we call prompt reporting. You have 5 days to let us know. But again, there were sort of large categories of things where it just didn't seem to make any sense to have them come in individually. We knew studies were halting enrollment. It was an institutional requirement. We knew that they would be screening subjects for COVID-19 symptoms if they were going to be seen in person. We knew there would be missed visits and study visits that would occur out a window. So those didn't need to be reported promptly, so long as they didn't put subjects at increased risk of harm. And we didn't want long lists of specific visits that were being held remotely for individual subjects. Again, so long as it didn't put subjects at increased risk of harm, and you still had to let us know that you were actually going to be implementing some remote visits. That's a fairly complicated set of criteria, so we developed a table, sort of a job aid that would help teams both triage what needed to come into us and what didn't, and to be able to document in their regulatory binder why they were not reporting certain things to the IRB. So if they ever get audited, they have that on file. We did permit our COVID-19 clinical research to get underway and enroll subjects. We thought that this was really important, and we did try to prioritize review of any submissions that involved COVID-19. In terms of investigational drugs, probably the one that most people will recognize is the remdesivir trial. We were a part of that, and one aspect that we're particularly proud of is we managed to go from receipt of the protocol at the institution to enrolling the first patient in a matter of 4 days, which is really unheard of. That is not the pace at which IRB and clinical contracts operates. And we will probably never see it again, but there really are no treatment options for patients, so we thought trying to get clinical research activities to them was an important goal to have. We did implement a number of COVID-19 convalescent plasma activities. Starting out, those all required individual approval from the FDA and an IRB chair letter of concurrence, and we were doing on the order of 8 to 9 of those a day before we could get them off to both an IRB review of a protocol and then an FDA approval of a protocol in general. We did a lot of, and are still doing a lot of biospecimen collection, since it's really important to the research community to have access to actual patient samples in order to develop diagnostics and treatments against COVID-19. There's a lot of really important secondary data analyses that are going on about how clinical practices might have changed, implications for patient care. There are a number of efforts to contribute data at either within our local institution, but also to contribute that data at the national level or at multi-site registries, since there's power in numbers, data numbers. We reviewed and approved a lot of survey data related to questions about telehealth, attitudes towards vaccines, and the impact of COVID-19 on a variety of populations, be them patient or community. And we had, I think, a really important role as an academic medical center. We have investigators who partner with a lot of our Worcester Public Health, Mass Department of Public Health, and the CDC in terms of public health initiatives. And it falls to the IRB to make a ruling that those activities are not human subjects research if there's any doubt or there's a need for documentation. And we took advantage of some new rules in the revised common rule where those sorts of activities are explicitly called out as not requiring IRB review. So that helped streamline things considerably. We are taking a risk-based approach to lifting restrictions, and I have come off a couple calls just earlier today where this is no longer the freshest information, but at the start of the month, now that the surge has passed and our clinical system is less stressed, although we do still have COVID-19 patients, and we did permit safety visits to resume without the chair's permission at the top of the month. And the plan was to reopen studies that have a prospect of direct benefit this coming Monday. In fact, we are probably going to push that back about a week in order to give the clinical system a chance to sort of adapt to resuming routine clinical operations before we layer any research activities on top of that. So that's the bad news for our investigators, is that they're probably not going to be able to get going as soon as they thought they might. The good news for our investigators is that we thought we were going to parcel out studies that have a prospect of direct benefit and then bring back studies that don't necessarily have a prospect of direct benefit. And I think instead what we're probably going to do is make sure that as long as staff are appropriately tested and can return to the workplace, as long as we can respect social distancing requirements, have the appropriate personal protective equipment we might need, that in fact it will be okay to reopen any type of research project. So I think there'll be some good news and some bad news for our investigators, which you now probably know earlier than they do, but that memo is coming soon. One thing to note is that as this has been going on and we've been working remotely and working from home, we have had to continue all of our range of regular IRB responsibilities just in a modified format. We do a lot of in-person visits with our investigators. We have an open door policy. They're welcome to drop by and talk to any one of our protocol specialists. That has now all shifted to being done remotely and by phone. All of our weekly staff meetings and daily huddles occur by phone. We are still managing or attempting to manage the regular workload for new studies coming in that aren't COVID related, still working to rely and review for other institutions with our reliance agreements. All of our web maintenance still has to happen. We are part of a larger human research protection program that requires some management, so all of those activities are still happening. And we did think about ways to replace some of the educational activities that happen in person. But for now, we decided that we would hold out and wait until we could resume those in-person activities. For now, they seem to lend themselves best to that. One is an Ask an Expert session where the IRB plus several other offices, including the library, actually make themselves available at a central location twice a month, and investigators can drop by. And since the IRB is in a part of the campus that doesn't get a lot of foot traffic, this has actually worked really, really well for us. We catch a lot of the foot traffic that we wouldn't otherwise, and we do play a role in some of our study coordinator courses. We try to hold those a couple times a year, and the one right now is on hold. We haven't yet adapted that to an online format. So for us, we're starting to think about sort of what is the future of work from home for the IRB on the med school campus. And I think my first response is that the timetable is necessarily set by the institution and by the virus itself, that the plans we might make today might need to shift as new information comes to light. For now, folks who can work from home are still encouraged to work from home. And as a group, we talked about sort of how that was working. And I thought it was interesting that some of the staff noted that while there were parts of working from home that made them more productive, not having to commute, being able to spend some quality time with family, it was just sort of a quality of life issue. There were some interesting adaptations. You couldn't print things out anymore and just walk down the hall and pick them up. You weren't going to print out a 30-page protocol on your home computer. And so having to be able to read and handle that material on your laptop is a challenge. Of course, leadership is always asking for the IRB, sort of what's your efficiency look like? We spend a lot of time calculating metrics, both in terms of volume and turnaround times. And we will take a look at those in the coming months as new data comes in. One of the things that I thought was interesting is that not only have we been working from home where we don't have the usual amenities and routines and practices that we normally have, which could affect our ability to turn submissions around in a timely fashion, but we've noticed actually a real uptick in volume, not just COVID-19 related research. So I think interpreting any of that is going to take some careful thought. So with that, I really appreciate your attention. Looking forward to hearing what Julie has to say about a slightly different environment, and I'll turn the floor over. Now, Eugenia, I believe I have to stop sharing, correct?
That is correct. And thank you so much for your presentation and taking the time, especially during an incredibly busy time when you're juggling COVID reviews and things are changing so rapidly.
Okay, I'm probably going to need a little guidance on stopping sharing. So my view looks different than when I tested the other day. And so I don't have.
I think it's worked.
Wonderful, thank you.
No problem. That wasn't me. I think it was all Martha.
Thanks, Martha.
Well, thank you again. And our last speaker, I'm very pleased to announce Dr. Julie Simpson, who works where I am at the University of New Hampshire. She's the Director of Research Integrity Services and an affiliate assistant professor of College of Teaching and of Education. She's been at UNH for 28 years. Her office administers the UNH Human Subject Protections, Humane Care and Use of Animals, Responsible Conduct of Research and Scholarly Activity programs, as well as UNH's Financial Conflict of Interest in Research and HIPAA programs. She's a member of UNH's IRB, IACUC, RCR Committee, and UNH's Radiation Safety Committee. She's UNH's Research Integrity Officer. She has co-developed and co-teaches a grad ethics and research and scholarship cross-disciplinary seminar that's been offered since 2005. She was the UNH project director for an Office of Research Integrity grant to develop web-based RCR training materials. She is an IRB member at 2 other New England educational institutions and has presented on research integrity issues nationally and regularly presents in UNH classes on a variety of research integrity topics. I'll now turn over the presentation to you, Dr. Simpson.
Thank you. Let me just add my screen. Okay. Thank you very much for the invitation to talk today. It's a privilege and an honor. So what I'd like to talk about, and I'm going to contrast with what Allison talked about from a biomedical perspective, is at the University of New Hampshire, we do not have a medical school. And so most of our research involving human subjects is what is called social, behavioral, and educational research. We're known in the IRB world as an SBER IRB. So UNH has 3 campuses. This is our Durham campus where Eugenia and I both work. This is Durham. This is UNH Durham at Sunset. We also have a campus in the state's largest city, that's Manchester. And we have a law school in the state's capital, which is Concord. We are a land, space, sea grant institution, and we just got it last year, an R1 designation, which means very high research activity, which is actually quite kudos to us considering we don't have a medical school. We have about 15,000 students, and we receive about over $100 million annually in externally funded research. So as far as the human subjects protocol portfolio goes, and that's what the HSR stands for, our IRB oversees about 900 active protocols. We do about 25% of ours are full board, 25% are expedited, and then 25%, sorry, I can't add up, 50% are what we call exempt level review, and we review all of those. Our full board reviews tend to be because they present more than minimal risk or they involve vulnerable populations. Let's see, our average activity is about 225 new applications annually. And I would like to note too that on the IRB we have a librarian, and also my bio, it was mentioned that I also run the Animal Care and Use Committee as well as our Responsible Conduct of Research Committee. We have a university level committee, and we have librarians on both of those committees, and they are such valued members of our regulatory committee community. And it's a pleasure to work with them. So I strongly encourage any of you who have the opportunity to become involved in research compliance in whatever. It's an eye-opening experience. So for a SBER portfolio, these are the types of common types of research that we see. It's not really surprising, but it's just a contrast to what Allison was presenting about the kinds of research they have. We have a lot of program review, evaluation research, pedagogical research, behavioral interventions, then the regular survey, ethnographic, and we do some physiological research because we have an exercise science program. Very active departments in the human subjects research world for us. Social work, psychology, sociology, communication sciences disorders is a growing program for us, and they are actually presenting us with more clinical research, which is a challenge for us. And we also have an institute on disability, which does a lot of research with individuals who have cognitive deficits. So they are one of our populations. As our children, college students is a large population for us, and also individuals who are economically or socially vulnerable. We also have 2 what are called subject pools. These in psychology and business administration, and these are, there are in each of these departments are classes that are research focused. And as part of the class requirement or course requirement, students have to participate in some kind of research. But because participation in research must be voluntary, there must also be non-research related activities so that they can earn the credits that they need towards the course grade. And so these psychology historically has a long time had subject pools, and there are many other types of departments that do it, but at UNH we just have these 2. So this kind of all came to a halt when we stopped in class on campus or in-person instruction. So for us, spring break was the week that this happened. So students did not return to campus after spring break. On that Wednesday, March the 18th, the university halted all in-person or face-to-face data collection. And where possible, it could be moved to remote, whether that was virtual, online, or by the telephone or by the mail. And if it couldn't be moved in person, then it had to stop. So you can imagine the kind of impacts that that might have had, particularly those for educational research, both in the K through 12 school systems, because a lot of those did not, they stopped in-person classes, as well as on campus. Behavioral interventions, we actually have a behavioral clinical trial, which is an intervention going on campus, and that was in its 3rd year and had to stop. So any campus-based research which required in-person basically had to stop. Another victim of this was program evaluation, because if the program stopped, and we can all imagine, I'm sure, all kinds of programs that did stop, because a lot of it required face-to-face, and I'm not just talking about, I'm talking programs out in the community. Research, evaluation research had to stop when the programs did, and then possibly pivot. So how did this affect our researchers? Well, they responded in different ways. Some of them just had to stop because they could not do their research, and I'll give you an example of that. I have a colleague who's in exercise science. He has 3 graduate students who all got IRB approval to start in-person studies with student athletes the Monday after spring break, and no student athletes came back to campus, and so all 3 of these graduate students could not conduct their research because it was all physiological. So she had to pivot for those 3 students. None of it could go ahead. So there was the halting. And then there was the modifying the protocols to move data collection online. And again, online, phone, mail. And those were usually surveys and interviews. Some people modified existing protocols that they could conduct remotely to add research questions related to COVID-19. And we saw quite a bit of this in pedagogical research where where instruction moved online, and now researchers want to look at the impact on college students about moving instruction online. We saw, like Allison mentioned, we saw new studies to look at the impact of COVID-19. They tended to be focused on New Hampshire residents and how it had impacted them, or again, the impact of the move to online venues. And then internally within UNH, there was a COVID-19 funding opportunity. So we had researchers who submitted protocols, submitted applications to that. And then those who got awarded, now they're in the process of applying to the IRB to conduct those studies. And then as my colleague's situation, the one I just highlighted, they had to submit new studies to change course for graduating students to try so that they could graduate, in fact, in May. So what to do for researchers? You know, some of these longitudinal studies were halted because of the nature of the study, and where the data collection could not be moved to, it had to stay as in person. We have researchers who got funding, federal, state, local, and they can't conduct the study as it had been funded. We have, again, students who got approved by a thesis or dissertation committee, and now their study could not go forward, all because they require face-to-face. Then we had researchers who had to learn how to conduct the research remotely using technology. And so while that may not seem like a difficult thing, you just set up a Zoom interview, it's does your study question, can it be answered in a manner that you can do it remotely? And then there was another challenge was to how to remotely recruit participants and get consent from participants if in fact it was all face-to-face based. So moving forward, so what are the implications? Well, for existing studies, we're going to have to, or researchers are going to have to factor in new safety measures to reduce the risk of COVID-19 exposure for both participants and staff. And they're going to have to train themselves and the staff on those new safety measures, whether that's PPE, disinfecting equipment, social distancing, all those kinds of things. For some, and it's not going to be a lot, but probably for the high-risk groups, will there be a new risk-benefit calculation needed because of COVID-19? So if you're bringing elderly people to campus because you want to do some physiological research with them, and they wouldn't normally come to campus, might you need to do a new risk-benefit calculation for that study by the fact that you need to bring people to campus? There will be possibly modifying the protocol to minimize COVID-19 exposure. So that could be reducing number of study visits, reducing the way you collect data, or moving online. And then there's the, you might have some great new opportunities for research questions related to COVID-19 to whatever the study is about. When we look at new studies, we could develop, researchers can develop studies to answer questions about the new situation in their field or their area of interest, or to ask or to answer existing questions in new ways. Researchers are going to have to plan flexibility in approaches, particularly when we're thinking about the school systems. Nobody has any idea really about what's going to happen in the fall, both in the K through 12 systems and in our institutions of higher education. So it's probably going to be the case that if they need face-to-face, they're going to have a plan A, a plan B, a plan C, depending on what actually happens. And then they need to be able to pivot their research if, in fact, conditions change in the middle of the term or the semester. They may not have to pivot their research agenda if they cannot continue the current course because something comes up that they didn't know about, or again, the larger environment changes or the context. They're going to have to include steps to minimize COVID-19. That's going to be part of the protocol. And they're going to have to do a risk assessment for the high-risk populations and maybe think about ways to reduce risk. Again, changing study visits, asking what people do, minimizing the number of staff in a closed room, those kinds of things. So it's certainly a challenge ahead for researchers, but with the help of librarians, the help of IRBs, we're all in this together. So I think there could be some excellent opportunities to learn and generate important knowledge about our world as we know it now and whatever it's going to be in the future. So I'd just like to thank you all very much for inviting me here to present. It's been a pleasure.
Thank you both for presenting. We're going to move into the Q&A session, and I will turn the microphone over to Jennifer and Lori.
Hey, hi, this is Jennifer. It looks like we had a couple of questions for Allison. There's a question, did any of your researchers experience any shortages of PPE or drug supplies that disrupted their timeline?
In terms of PPE, there were no direct reports, so I can't turn around and say we had frantic calls about folks who didn't have PPE. Because we work in a clinical system, one reason why things like non-essential visits were stopped were so that the priority use for things like PPE would go to patient care as opposed to research activities that were not essential to the well-being of the subject. We did have some really interesting calls come out, folks looking for donations of equipment in various ways to try to support the response. And in terms of drug supply, I can't speak to the clinical system. There really aren't any. I mean, remdesivir is really the closest thing we have to a treatment for COVID-19, and there are sort of nationwide processes to gain access to that. Within the state of Massachusetts, the hospitals that received supplies ended up sending it off to the Mass DPH, which then was able to distribute it equitably throughout the state. So I thought that was a really, really nice response to that.
This question came in during Allison's panel, but I think it can apply to both of you. How did COVID impact ongoing research projects, and what has been the procedure for dealing with those changes?
Julie, I think you probably spoke to that more directly in yours. I don't know if you want to recap.
Sure. So the main thing was having to stop all face-to-face and, if possible, pivoting to online or virtual or mail or phone, whatever that may be. So it was thinking creatively, especially for some projects where that might not be, you know, the best way to collect data. The challenges were, I think, with the timing of it, and just also at the same time, a lot of our researchers who are faculty had to pivot all their teaching online. And so not only were they trying to figure out their research studies, they were trying to figure out how to teach the rest of the semester online, and they may be having to figure out all their students who couldn't conduct their research and who were graduating. So I think actually maybe a lot of research took a back seat, but at least in our world. It's not like clinical research, just because of the nature of so much going on. I mean, our poor researchers who are teaching faculty too, just their lives were turned upside down, let alone all the things going on at home as well.
Another question that came in during Allison's talk, but I think could apply to both. Did any changes in the federal funding pipeline affect your projects or new submissions?
So I can take that. I know we had a number of inquiries from federal funders and from industry sponsors who wanted documentation from us about timeline, sort of when certain things were happening so that they could document when they weren't going to be able to meet deliverables or to meet certain pieces of a protocol. And so we did try to have that documentation ready for them. I think Julie mentioned there's actually a number of funding opportunities that have come out of COVID-19 as well that our investigators are taking advantage of. So, you know, you win some, you lose some.
Another question for Allison. Have there been any issues coordinating changing FDA guidance with institutional restrictions?
So that's an excellent question. So for all of our greater than minimal risk research, you have to document consent in writing. And yet, when you are a COVID-19 patient, you can't have any visitors, you're often intubated, and figuring out how the heck you're going to have a family member sign a consent form is a real challenge, and minimize any sort of infectious process for staff. And, you know, these consent forms are on the order of, they can easily be 10 to 20 pages long. They're not short. And so it took FDA a little bit of time to come out to sort of talk about some alternative ways to actually do that and have witnesses and take pictures of things. And they really only recently have come out and made an app available that they run, which will facilitate documenting consent in writing in a remote process. It's real challenges there. We did our best to address them and support our investigators. I think it will be interesting to see what happens as all of these trials move forward and people look at the documentation that's available.
Question for Julie. You touched on this a little bit about the increase in new projects due to COVID-19 research. Do you think that truly is the case? COVID-19 is increasing the project? And if not, why do you think you're seeing more submissions right now than you usually would?
Well, it's funny. We actually haven't had a lot of projects relate that we can see a COVID-19 because we were tracking them. There were a few, but I had a colleague who's volunteering at another institution, and she had 80 protocols of the social behavioral sitting on her at one time, and it's like, no, that's not us. So, but it's that time of year anyway for new protocols because summer's coming up for summer research. So from our own perspective, it wasn't due to COVID-19 that we got new protocols. It's just the nature of the flow of academic research for us.
I think this question could be for either of you. Are there situations where in-person interviews cannot be done as phone or Zoom interviews, not necessarily due to technical issues, but because of something in particular that the researcher is looking for?
I can take that for a couple of things. One is if you're going to do any kind of linguistics research, probably that is a technical thing, but you really probably couldn't do that over a Zoom just because you can't get the level of fidelity of a recording. You might also have, you know, if some things like you want children to do something, you know, you're not there and you can't do the actual thing with them. And then it depends, it really depends on the nature. Like you could have some very sensitive research that you wouldn't want to go over the internet, even if it was encrypted. So those are three that just kind of come to mind for me.
If you have subjects living in rural areas, so say your research was allowed to continue, were the investigators able to use video conferencing software, or were there technical disparities, and was it possible to switch over to phone calls?
I mean, I didn't hear of anybody. Actually, what I do hear is, you know, cell phones in our North Country. We have a lot of mountains, and cell phones, you know, coverage is not good. But if you had a hard wired into your house for like a, you know, for Wi-Fi or something like that, you probably have better luck. So, but I haven't received any reports of people continually having to switch or requesting different types of technology just because of technology issues. So.
Yeah, we don't have any reports either. Yeah.
What do you recommend for librarians to best support our researchers in regards to the IRB process at this time?
Well, I would just say make yourself available. I mean, so for instance, my colleague who had the 3 students, she had to turn them all on to meta-analyses. And so he, you know, like marched them off to the librarian and said, okay. So I think coming up with a, you know, brainstorming amongst yourselves about the types of support that researchers have been asking for, and then advertising within your own institution about, hey, if you want help with student with this, this, and this because of COVID-19, you know, send them to me, because they actually might not have thought of the types of resources, help and assistance that you might be able to give them. So I would come up with, you know, I would take that tack and advertise your myriad services to help researchers and their students at this time.
Yeah, I think as the librarians work with the medical students here, having a sense, this is true for faculty as well, really anyone who serves on the IRB, you get a new appreciation of why the IRB is asking for the information that it's asking for. And to be able to communicate that to a student who's trying to put together application and a research project that's going to pass IRB review, I think they play a really important role in that sort of mentoring.
And sort of a related question from the Q&A, and I've seen this as well, that there's a lot going around about this is the time of the review article versus people doing primary research. Do you have any thoughts or predictions about that type of research, review articles and things going forward as opposed to people conducting primary research?
We're busy. So, and we're not reviewing review articles. So I think they're, the best I could say is we're busy. So people have not given up. They've adapted or they've turned topics. And so while we may see review articles, and I think there'll be a lot of data coming that will be publicly available, whether it's aggregate data or available here, that I hope people can take advantage of without needing IRB review. I think that'll be a service going to researchers going forward.
Billy, any thoughts on that?
No, I think, you know, the whole area of review articles also has a disciplinary, you know, bent to it too. So there are some disciplines where that's much more, not acceptable, but more common and people do it, whereas for other disciplines, it's really not in their, not scope, but it's just not what they really do. Now, it's not to say that they can't do it or shouldn't do it, but yeah, I'd say it's probably field specific for that.
Okay. How did the restrictions on international travel affect researchers and IRB timelines?
I know I can speak. We have a whole international research opportunities program, and all the poor students who'd written their applications all got funded, all canceled. So, I mean, it was heartbreaking to hear about all the, because we'd actually, in the IRB and the IACUC, we had reviewed and approved some of the protocols already, and they just all got canceled. As far as, yeah, it basically shut down any, you know, kind of ethnographic or any type of that research. Only the research that really could be done virtually could continue from our perspective.
Yeah, it's not a huge impact on us. We do have some projects that are international, and really the restrictions that were in place apply just to our campus. So if there were external sites that were in place and researchers were able to be there, we would permit them to continue, but it's not a huge part of our portfolio.
Are any of these changes things that you could see remaining if the pandemic is resolved, such as that app for the consent form?
Yeah, I would like to see FDA sort of rethink some of the requirements for what needs to be documented in writing. I don't think that's going to happen, or it would require a major shift in that, but it's nice that they made some things available. We are working. It has shifted some of the processes that our IT is taking in order to provide some better resources to our investigators who do that type of research. For us, I think the big shift is actually going to be within the IRB office, where we are not a work from home shop as a general rule, but I don't see us returning to the office anytime soon. And still being able to maintain a level of service that we like to deliver is going to take some accommodation.
I think that looks like all of our questions. Thank you very much. And we'll leave it to Eugenia to wrap up.
Again, thank you to both of our speakers. This was enlightening, and I know it's a very busy time, and we really appreciate the time that you spent to put all this together. So to the audience, we've now reached the end of the session and the end of the Virtual Science Bootcamp. Again, thank you to our speakers, and a thank you to the audience for taking the time to attend this virtual conference.